Psychiatric emergencies. You will deal with several psychiatric behavioral emergencies during your career. The more stressful times are, such as the times we're in right now, obviously the more behavioral emergencies that you will come in contact with. The crisis could be something that is emergent, that a situation set them off. It could be mental illness. It could be some mind-altering substances, drugs, or alcohol, and it could be stress as well. Behavior is the manner in which a person acts or performs. Maladaptive behavior is where the way you act is not acceptable with the group that you're within. So a psychiatric emergency is a situation in which the patient exhibits abnormal behavior within a given situation that's unacceptable or intolerable to patient, family, or community. So again, very simple terms. If your behavior is not acceptable by the ones that you're around at the time, then that is considered unacceptable behavior or maladaptive behavior. There are several things that can cause behavioral emergencies, such as low blood sugar, hypoxia, inadequate blood flow to the brain from a stroke, head trauma, environmental emergencies, psychological crisis. A lot of these you can rule out, such as the hypoglycemia, the hypoxia, and so forth, but sometimes treating the underlying cause will take care of the behavioral problem. Psychosis is a state of delusion in which a person is out of touch with reality. If a person is delusional, they think things that are really not true. David Koresh thought he was the second coming of Jesus Christ. So if you have someone who is out of touch with their own reality, then that is called delusional. Delusion can typically be reversed. We just have to, if there's a situation that's causing the delusion, then if we can take that situation away, then the delusion will probably go away as well. Schizophrenia is a complex disorder that is very difficult to define and also to be treated. People who are schizophrenic tend to be delusional. Hallucinations are things that they think that are there that they see that are not truly there. They have a sudden lack of interest in pleasure. They have erratic speech, and these people can be extremely violent. So you need to make sure that the police are there if you're coming across a schizophrenic patient, because they can tend to be violent with other people. Delirium is a condition of cognitive function that can present with disorientation, hallucinations, and delusions. A big difference between delusional and delirium is delusional can be reversed, delirium cannot be reversed. Delusional is more of a focus or a focal issue in the brain, whereas delirium is more global within the brain. They tend to get very agitated and restless. A lot of people equate delirium with I'm sorry, I have misspoken. I'm getting delirium and dementia mixed up. Delirium is reversible, as well as delusional can be reversible as well. So delirium can be reversed if we can figure out the reason why they are delirious or why they are delusional. Then if we take that environment away from them, then we can usually take care of the delirium that way. Delirium is more focal, and again, it can be reversed. We'll talk about dementia when we get to either in this chapter or when we get to the geriatrics, which will be next. Agitation is characterized by people that will strike out irrationally at other folks. So again, your personal safety needs to be job one. You'll go out on several folks that are depressed. This is the major cause of people wanting to commit suicide, or at least attempt suicide. It's a common misconception that people who threaten suicide will never commit it. Suicide is a cry for help. Attempted suicides are more of a cry for help than someone that goes off into the woods and does a job of committing suicide without telling anyone. But you'll see some suicidal attempts that are a lot more intentional than what others are. I have gone out on patients that 19 years old tried to cut his wrist with a butter knife, a plastic butter knife at that, never even broke the skin with it. That's a cry for help. However, when you have a patient that climbs up in a tree with a rope, a handgun, a gallon of gasoline, and a match, and he puts a noose around his neck, hangs it from the tree, douses himself in gas, sets himself on fire, and then shoots himself in the head. And when he shoots himself in the head, he falls from the tree and is hanging. That's kind of gone beyond a cry for help. That is a person that really wanted to commit suicide. So what are some risk factors? Well, we're in a very stressful part of time right now, probably the most stress that most of us have seen in our lives. So this is a huge contributor is the stress levels that people are under. Loss of a job, loss of a loved one, arrest or imprisonment, and a serious illness. So who is more likely to commit suicide? The 15 to 25-year-olds, you think about your life in high school, junior high and high school. You guys had to put up with something I never had to. We didn't have social media when I was going through high school, and if you were bullied in school, it was pretty much face-to-face bullying. Now there's cyberbullying that can be just as damaging as face-to-face bullying is. College years, you get out of school, you get your 4-year degree in 4 years, and you get out and you can't find a job. You have to move back in with mom and dad, and you're working at McDonald's for $10 an hour with your 4-year degree. Once you get over the age of 40, you kind of tend to go through a midlife crisis at that point. But also don't discount the elderly as well. Usually the people that are over 65, they have the best success rate, so to speak, of committing suicide. They think things through. They don't just on a whim decide to do it. They really think things through. Women attempt suicide more, but men are more likely to succeed at the suicide attempt because men tend to use more definitive methods such as guns and so forth. Women tend to do overdoses and so forth. The more laid out plan that they have, the more likely they are about how serious they are about this suicide attempt. If they've had previous suicide attempts or have threatened suicide before, alcohol or drug abuse, and then all of a sudden someone goes from a depressed state to, yes, they're still depressed, but they're improved, sometimes those tend to be your risk factors. So here we have a very angry person in the house. You need to make sure that you have an escape route. You need to make sure that you are between them and the door and not the other way around. Make sure that you don't ever enter into a scene alone. If you feel it's going to be like through your dispatch, if you feel that it's going to be a scene that is dangerous to begin with, then you might wait till the police get there and let the police go in first. Remember, guys, you're in their house. They know where everything is, and you don't know where anything is. So you have to keep your keep your senses aware. Do your scene size up and your safety concerns. If the police need to be called, then by all means use them. Do your patient assessment. Try to calm the patient down. Please don't ever leave the patient alone. There have been cases where psychiatric patients have been left alone and they ended up committing suicide. So make sure you do not leave these folks alone. Is the situation unduly dangerous to you and your partner? Then you need to leave. If you need law enforcement, then get them there and get them there early. It is not abandoning your patient if you leave a scene that you feel is not safe. Does the patient's behavior seem typical or normal for the circumstance, or is it a little bit bizarre? And are there legal issues? There's always going to be legal issues involved with a psychiatric patient. Use positive body language. Don't try to overpower them with your body language. It's always good to try to kind of stand sideways to them. That way, if they do want to come after you, then your vulnerable parts, your torso and your face, are not facing them. Acknowledge the patient's feelings as real, even though you may not think that they're real. Stay at least 3 feet from the patient. Nowadays, we do the 6-foot distancing, but in this case, 3 feet away from the patient. And make sure you're alert for the changes in people's emotional status, because it can change on a dime. Begin your assessment from the doorway or from a distance. Try to do a rapid scan of not only your patient but the room as well. And you should be able to tell from across the room the AVPU scale to see if they're awake or if they're unconscious or somewhere in between. Identify yourself. Let them know that you're EMS and that you're there to help them. Speak very slowly and clearly. Use a calm, reassuring voice, and please don't be judgmental with these folks. Again, whatever they're telling you, you need to take as that's what they're feeling. However, you also need to adjust them to what reality really is. So be sure to listen to the patient. What's the patient's mental status? How do they look? Some people choose to look grungy every single day, but if this person normally dresses to the nines and all of a sudden they're not looking, the family tells you that their hygiene and their clothing has really become ragged lately, then that's a pretty good sign that they're going through some type of emotional issue. Are they speaking clearly? Are they saying things that just don't make sense? Are they confused? Do your AVPU, and then are they conscious, alert, and oriented times person, place, time, and event? Someone can be awake, but they're not oriented. All right. I mean, their eyes may be open, but they may not know where they are or who you are, or who they are. So make sure that they not only are alert, but are they oriented to what's going on as well. All right, so I hope that this guy is not inviting him to come on. I hope this is just, hey, buddy, I see your fists are clenched here. Obviously, you're upset. What can I do to help you? So hopefully there's another medic or EMT around here somewhere. Hopefully the police are already here. But just be aware that this person is angry, and you can tell by his body language that he is. So do your ABCs, Ds, and Es on these folks if you are close enough to get to them to assess these. Ask them, how do you feel? Ask them if they have ever thought about committing suicide, or are they thinking about committing suicide right now. Those are not obtrusive questions or intrusive questions. If they're suicidal, then you need to know about that, because all suicidal patients need to be transported to the hospital. Are they a threat to themselves or others? Have they attempted to harm themselves either today or in the past? Is there any kind of medical cause? I mean, have you been diagnosed by a physician that says that you have a mental issue that you're going to have to deal with probably the rest of your life? If you are on medications, is the patient compliant with their medications? Are they taking them the way that they're supposed to? What's their history of violent behavior? Just because someone does not have a history of violent behavior doesn't mean that they can't all of a sudden become violent. So how are they posturing? We saw the gentleman earlier with his fist clenched. What's their voice level? Are they yelling? Please don't yell back at them. Usually when you talk to them in a calm voice, they will stop yelling at you. And look at their physical activity. Are they pacing back and forth? Are they clenching their fist? Do you see their jaw clenched? Make sure you stay far enough away from them and when you're doing your interview. And it's always a good idea to have something between you and them that can get in the way in case you do need to retreat. So a chair or your stretcher or something that they're going to have to move out of the way or jump over to get to you. Encourage the patient to talk. Don't make quick moves towards them. Respond honestly to their questions, unless if they're hallucinating and they go, well, look at that pink elephant in the room. Again, you need to establish reality with them at that point. Don't buy into their hallucinations. Don't threaten them. Don't play along with their visual or auditory disturbances. and be prepared to spend time. You may have to spend a lot of time with this patient to convince them to go to the hospital with you. Try to avoid as much physical contact as possible, but make sure that you keep good eye contact. If you turn your head for just a second, they may jump on you, so make sure you keep eye contact with them. If you do need to restrain them, you certainly can restrain them as long as you can prove that they were a threat to themselves or they were a threat to you. So if you do restrain them, make sure that you document at least 3 things on your report. Number 1 is, why did you restrain them? And all you have to do is say they were a threat to me. Number 2 is, what did you use for restraints? Did you use commercial restraints? Did you use the straps on the cot? So what did you use to restrain them with? And then you need to document that they had good pulse motor sensation before you put the restraints on and after you put the restraints on. Try to get the vital signs as well. Again, sometimes they may be too violent for you to get near enough to them to get vital signs. Never let your guard down. Again, if restraints are necessary, make sure that you restrain or that you reassess your patient every 5 minutes to make sure they still have good PMS distal to the restraints, make sure they're still breathing. Please never, 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 never restrain somebody prone. All right, they always need to be in a supine position if you're going to restrain them. So there's really not a lot you can do to treat this patient. You can try to diffuse the situation if possible, but taking them to the appropriate hospital will be what is about the only treatment that you're going to do for this patient. Reassess everything en route to the hospital. Sometimes these people who have had a psychiatric issue for a while, they know how to play other people, so they may want to be your best friend, and then about the time you let your guard down, and they jump up and come after you. So you have to be very, very careful. You can use reasonable force, and reasonable is the key word here. Okay, once you get them restrained, and then you don't need to take any more reasonable force on them. Just remember, how big is your patient? If you got a lineman for a professional football team, it's just you and your partner, I don't know that I would try to take that patient down and restrain them. If they're acting so bizarre that it scares you to even think about restraining them, then you probably don't need to. Guys, be very careful when you are men, when you're restraining a female patient. Sometimes they'll come back and accuse you of sexually molesting them. What's the mental state of the patient, and then what type of restraints do you have at your disposal to use on the patient. So you need to have adequate help, and sometimes if there's 6 of you there against 1 person and there's a couple of cops added to it, sometimes people just realize that they're outnumbered and they'll comply with you, but if they don't, then you need plenty of help there. Make sure that you plan ahead and make sure you know what you're going to do. If you go in with no plan whatsoever, it's not going to turn out real pretty. So once a decision is made to restrain this person, you need to have a minimum of 4 people, 1 for each limb. You need to have 1 EMT talking through the process, and then again, make sure that you secure all 4 limbs. Supine. You're a lot better by restraining a patient to a long backboard than you are to the stretcher. That way, when you get to the hospital, all you have to do is take the long backboard with them still restrained to it and move it over to their gurney without unrestraining that patient like you'd have to if they were restrained to the cot. So positional asphyxia, this is what we have seen over the last 2 weeks. When you have a restrained patient, most likely they are going to be in a prone position that causes this, and they asphyxiate. Basically, they just suffocate and then they die. So this is called a hobble or a hog tie. Again, we never do this. We have a lot of things going on that's wrong with this patient. They need to be face up. They don't need to be prone. They don't need to be hobbled like this. I don't know how you're going to assess vital signs with this patient with them in this hobble position. So this is a no-no. Please do not do this. If the patient spits, you can put a surgical mask or you can put an oxygen mask on the patient. Make sure that you document, like I said, why you restrained them, the method that you restrained them, that you check PMS before and after, and then any witnesses that were there. A lot of times emotionally disturbed patients will refuse transport or even refuse care. So the first thing you'd like to do is try to talk to family members if you can. Now, the family members may be the reason that they're having an emotional outburst, and so that's probably not the best idea to talk to the family. But if the family can talk to them and talk them into accepting care, then great. If that doesn't work, you can certainly call the police. If the police are there, you can see if they have a dog in this hunt. If they don't have a dog in the hunt, then your last resort is going to be calling medical control and see if medical control can talk to them and see if they can talk them into accepting your care and transport. Okay, so now we're going to move on to geriatric emergencies. I can tell you, as depending on what you call geriatric, I'm getting closer every day if I'm not one already, but getting old is not fun, but it certainly beats the alternative, which would be dying. So there's a lot of issues that are going to happen as you get older that there's really nothing you can do to stop this. However, just because you're old doesn't necessarily mean that you're blind. It doesn't necessarily mean that you're hard of hearing. So there are some things that do go along with getting older, but not all of them are inevitable. Okay, so according to this, I'm not a geriatric yet. So a person who is 65 years or older, every single day, 65,000 people turn 65 in the United States. So you guys will see a lot more geriatric patients than I ever thought about seeing. I'm part of the baby boomer generation, and the baby boomer, I'm kind of right in the middle of that span. And so when I get to be 65 in 2 years, then you'll be halfway there to all of them in the baby booming generation getting to age 65. So you've got to make sure that you understand and appreciate how the life of an older person is going to be much different than you as a younger person. It's going to take a lot more time and patience on your part to interact with the elderly because they don't hear as well typically. They don't understand things. They understand things, but it takes them a little bit longer to understand things. And when they're answering your questions, it may take them a little bit longer to formulate an answer to give an answer to you. So have one person and one person only talk to the patient and ask only one question at a time, and don't ask another question until that question has been answered. You also need that one person to be in a well-lit room and in front of the patient. That way, in case they do have some hearing issues, they may be able to read lips. If they need to put their glasses on or put hearing aids in to assist, then by all means assist them with that. Give the patient time to respond because it's going to take a little bit longer for them to respond to answers than the younger population. Listen to the answer and then explain what you're going to do before you do it. So hip fractures are very common in the elderly. They say that hip fractures are a death sentence for an older person, and what that means, it's not that they fall and break their hip and they bleed to death. It's typically the lifestyle that they lead after that hip fracture, the sedentary lifestyle that they tend to lead. They tend to throw blood clots and so forth. So, if you stay active after a hip fracture and you get a hip replacement, then, that should be great, but a lot of people are not able to do that. Nearly half of the elderly population have got some type of either bone or joint disorders like arthritis or rheumatoid arthritis or something of that nature. They're more likely to have their bones weakened by osteoporosis, and women are a lot more prone to having osteoporosis, especially once they reach menopause, than males are. And infections can also cause some weakening of the bones as well. About a third of the elderly have got high blood pressure and heart disease, and the sedentary lifestyle that They tend to lead as they get older, can lead to higher instances of pneumonia and blood clots. And of course, blood clots are going to cause pulmonary embolisms and strokes. So half of those over the age of 85 or older live alone or with a spouse, but only 5% live in nursing homes. So that's not a lot when you look at the statistics here. 5% is not that much, but there's still plenty of folks in nursing homes that you'll be dealing with. The 1% rule, starting at age 30, our organ systems start to lose about 1% of their function each year. So this can make it very difficult for you to assess normal effects of aging versus effects of disease processes. So some of the more common reasons that the elderly call 911 are they have cardiac or respiratory problems, neurological like strokes, or they have altered mental status. We have the weak and dizzy, or the general malaise, which general malaise is just like you feeling blah. A lot of them fall. A lot of them have throw rugs in their house. They have lap dogs that get underneath their feet. Some of them just fall. I mean, there's nothing that really made them fall. They just fall. So if an elderly person has fallen, you need to ask them a couple of questions, such as, what made you fall? Did you trip and fall, or did you pass out and fall? If they passed out and fell, you've got a medical issue that preceded a trauma issue. If they tripped on a throw rug, then that's trauma from the get-go. So if they have any type of hearing or visual impairments, if you can assist them with their glasses or their hearing aids, then great. You're probably going to be a lot easier to understand if you have them put their dentures in, if they're denture wearers. And try to use plain English and simple terms that they can understand. Confusion, don't assume that confusion is normal for anybody, including the elderly. They sometimes that is their normal, that's their baseline. If they have Alzheimer's, then certainly confusion is their day-to-day, but you need to find out if they are confused. How long have they been confused? If they've been confused 10 years, obviously that's something that's chronic. If they've just been confused the last 2 days, then something may have happened in the last 2 days that causes them to be confused today. Do your scene size up, your assessments, everything just like you would on any patient. Are there physical hazards that could produce injuries? You might want to do a little community education with these folks, whether you transport or not transport. You might want to get rid of these throw rugs. You might want to have someone put the dog up if they keep getting under your feet whenever you get up and you walk from one place to another. You notice this dog at the end of the stairs. Stairs are going to be an issue as well. Some people have a hard time going up and down the stairs, but Fido's down here at the bottom of the stairs, and he blends in with the carpet pretty good. So if your vision is not quite what it used to be, then you may not ever even see the dog here. This is their bag of meds. Are they organized and are they current? Some people have the Monday through Sunday deals that they put their pills in. You don't know what's in there because it's just pills. So you need to find the pill bottles and find out what is in that Monday through Sunday pill container. Do you see half-eaten food? Do you see no food? Are the surroundings sanitary? What's the temperature of the home? Now, as you get older, you tend to get colder than you were when you were younger. So it's not uncommon at all to see Mamaw in a sweater in the summertime because, she does get cold. But, if the heater's on during the summertime, that probably doesn't need to be happening. Even though Mamaw says that she's feeling comfortable, she may not know that she even has the heater on. So what's their level of distress? And, probably when you go out on these elderly, you've never seen them before. So you're going to have to get an idea from bystanders or family on what's their baseline? How are they normal? How are they positioning? Do they have any, are they laying in a hospital bed? in the house? Do they have oxygen tanks? Do they have a feeding tube? What is their normal baseline mental status? And that way you got something to go off on when you're starting to talk with them. Their airway may be affected by either they can get arthritis in the neck. I found out about 5-6 years ago that I had a little bit of arthritis in my neck, and so that can happen. Kyphosis is where you have a humpback at the top of your back. You see a hump, and you see, a few older people with that kyphosis. That can cause them to have some breathing difficulties as well. Loose dentures can cause some airway blockage as well. A lot of them have got irregular heartbeats. I won't say that that's just goes along with being old, but a lot of them do have irregular heartbeats. They may have a huge, lengthy medical history, or they may have none at all, or they could have in between. Same thing with the medications. They could have a cabinet full of medications, or they may not be taking anything. Some of them take ownership of themselves, and they know exactly what's going on with them and what the problem is. Other ones don't have a clue. They just know that, I take this little blue pill to make me pee. I'm not real sure why I take it other than it makes me pee. So some of them just are not quite as educated as others. Their skin is probably very thin, a lot thinner than it was when they were younger, so it can be very fragile as well. You could bruise them. You could tear the skin, so you need to be very careful when you go to lift them up. Make sure you protect the patient's modesty. They seem to be a lot more modest than the younger generation these days. Be aware of their loss of independence feelings. Let's talk about as you get older and losing that independence. One of the hardest days in your life will be taking your car keys away from your mom and dad. I had to do that with both my mom and dad, and it's extremely difficult to do. What's even going to be a worse day in your life is when you have to move them out of the home that they've lived in for 30 or 40 years because they can no longer take care of themselves. You have to put them in a nursing facility where they can be taken care of around the clock. So losing your independence is a huge deal when it comes to getting older. Make sure that you take extra time to pad on bony parts that would be up against along backboard or any type of void or curve that you have in the patient. Make sure that you take extra time to pad or cushion under those areas. So as you get older, your blood pressure does increase. And so like we talked about during cardiovascular emergencies, just because a woman this age, her blood pressure is 110/70, that does not mean that that's a great blood pressure for her. That may actually be hypotensive for her. A lot of folks are on antihypertensives to keep their blood pressure at bay. The skin loses its elasticity as you get older. That's why we all have droopy skin as we get older. And their pupils may not be equal and reactive. They may have glaucoma. They may have cataracts where you get the film on the lens of your eye. Some of them may be blind, so their pupils may not be reacting like they did when they were younger. So this lady, did she fall? Is she a victim of abuse? You need to get a really good story to find out exactly what happened. And if there's any doubt in your mind that this is abuse, you need to let the police know and let the hospital know when you get there that you suspect that this may be abuse.